it's almost uncanny what people are able to do once they recover. And the addicts are rich, wonderful, smart. It's one of the reasons I like working in the field. That's part of the...
Thanks, Drew. I do feel
No, they are. They are.
Dr. Drew, we're back together again.
Here we are. It's only taken 10 years to get back here.
Well, you know, the best things do take time, right? I'm so glad for the wait. It's good to see you, my friend.
Just think, if you wait another 10 or 15 years... No, don't.
I won't, but we will both be here in 10 or 15 years.
Good. I'd like that.
Listen, I am 52 years old, and I had this very clear vision on my 50th birthday that I would live to 100. I know it. It's where it's going. I'm living to 100. So I invite you to stay alive with me.
I would love to, but I'm a bit older than you.
That's all right.
So,
I don't judge.
All right. If I can make it to your 101st birthday, oh, God.
Unreal, right? That'll be the podcast of the century. So, all right. So 10 years, how you been?
Good. I mean, a lot of things have changed, right? Kids have grown up. We've had this little pandemic thing came in the middle of everything.
I've heard of it.
I guess I don't think in terms of those 10-year blocks, but a lot has gone on in those 10 years.
Isn't it wild to see how quickly it goes?
Don't even. But it gets worse. It's the one universal sort of observation in all cultures. There can be all sorts of variation in ideas about art and meaning of life, but one universal truth prevails in every single culture. Excuse me, ever examined, and that is that time speeds up as you get older.
Why is that?
Nobody knows for sure.
I don't like it.
I hate it.
Well,
but 10 years. It's weird. There was pre-COVID and post-COVID, which is two different lifetimes.
Yes.
And there was, I was doing a lot of different things. Radio was a business at one point. Now radio doesn't really exist anymore.
Right. Before there was podcasting, it was just radio.
Just radio, and it was very powerful. And I was on CNN for 8 years.
Right.
I was doing HLN every night.
I think that's when we met, that you were promoting that show. Yeah.
I'm sure I was doing that. And now what?
Here
we are.
And here we are. So I know you are a man of many talents, but I think what people really know you best for, and what I'm most interested in talking about, given the title of this podcast, Soberness.
Yes.
I'm so interested into what attracted you to addiction treatment.
Yeah.
As an addict, I can tell you it's a horrible world. Nobody would want to be a part of it. And you went right to it like a moth to the flame.
Well, no, it wasn't. Yes, I was like a moth to the flame, but it wasn't with that sort of premeditated motivation. So the story is, I was John Q medical student. No, I was actually a resident. I guess I was a resident. I finished my first year residency and was on a cardiology rotation. I'm an internist by training, and cardiology was actually my thing. I probably would have become a cardiologist had I not gone down this psych hospital path. And this cardiologist comes in and goes, "Hey, the psych hospital down the streets needs some help. Any you want to moonlight?" And I was like, I just got my license and everything, and sure. And it was in Pasadena where I'd grown up, and I'd always heard there was this mysterious old psych hospital there. Well, I went in there, and I was blown away. It's a 150, 120 bed psychiatric hospital, beautiful old Gothic buildings. Every psychiatric hospital that you saw in old films was fashioned after this place because guess what? All the alcoholics and all the depressants and all those Hollywood stars were treated at this hospital.
Oh, wow.
Everybody was treated there at one time or another.
Anyone who was anyone in addiction.
Well, not just addiction, but anything. I mean, I was sort of enraptured with the place. I was always interested in the brain. I was interested in psychiatry. I thought I knew something about it. Lo and behold, it took me about 10 years to really learn what I needed to know. And I started moonlighting there, and I became very good in the medical care of psychiatric patients. And over the years, I ended up taking over their medical services department and running these really being right at the interface between medicine and psychiatry. But when I would be there at night, they'd have one of us stay overnight there. I always was drawn to the drug unit. It was this separate unit. If you read my book, Cracked, it was about that unit. And it was this separate unit down in the center of the facility, away from all the psychiatric stuff, had its own cabins and things. And it had just a totally different culture and a different kind of staff. And they were just seemed more, I don't know, lively, fun, interesting, more alive. And it wasn't, depression wasn't the hour of the day, and people weren't psychotic necessarily. And because I was there for the medical reasons, which there were tons of course, drug addicts get sick and have all these medical things. I also got very good at treating drug withdrawal. And so over the years, I was spending more and more and more time down there. And I remember I used to look. There was a window from the nursing station into the treatment room, where you have groups, and on the wall, the 12 steps were on the wall, and I used to just think, oh, what is it? I'm getting these people off drugs.
Right.
I'm doing what is that silly stuff? That silly 12-step stuff, and I ended up watching a few patients go from early in treatment through a few months of treatment, and I couldn't believe it. I was like, what just happened? I remember these two sisters were the ones that sort of asked me to follow them. They were one of the first cases I saw all the way through, and they were dying when they arrived. They were young women who were dying of drug addiction, and they ended up like amazing. And I was like, what happened? In general medicine, you're going from acutely ill to chronically ill, not from dying to better than you ever knew you could be. That was just astonishing to me. I thought, I need to understand what's happening here. So I got more involved, started asking more questions, spent more time down there, started trying to work on things, on the process of treatment. And the director then asked me to be the assistant director. And he was like, the way he sold it to me was like, no big deal. You're there all the time anyway. It'll just be on the holidays. I'll be gone for a couple of weeks. And, if you need psychiatric backup, we'll have somebody there for you. I was like, all right, I'll take the assistant director job. 6 months later, he quits. Now I'm the director of a drug unit. I'm an internist. I'm not a psychiatrist, but this is 1991. That was unheard of, to not have a psychiatrist running these units. And I thought, well, first of all, I'm never going to see a job like this again, so I better hang on and see if I can make something of this. And I got some work to do to really get my level of sophistication and expertise up to where it needed to be. And so I took the board certifications and I started really working on it. And it was this great experience of living at the crossroads of everything: medicine, psychiatry, neuroscience, spirituality, family systems, psychology, psychiatry. It all happens on a drug unit. And we eventually assembled Camelot. We assembled this great team of people that were just exceptional talents. And even when the drug unit was like, it really was not ever a business, because it never made money. Because if you do it properly, it's almost impossible to make money doing that work, because it's just, there isn't enough manpower to do what drug addicts need. You can't pay for it and have a business.
I mean, it seems to me like a lot of people are doing a lot of business around trying to get people sober these days.
If they make a lot of money doing it, beware.
Wow.
Because it's probably not the level of service you should be getting.
Okay.
And by the way, let's remind ourselves, here's the thing that drives me absolutely out of my mind, that there is now with a large Cochrane analysis, Dr. Kelly at Harvard proved that mutual aid societies, i.e. 12-step, has equivalent proven efficacy to any professionally managed therapy, and is superior when abstinence is your goal. And it's free and it's available 24/7. Why would we push back on that? It's free and it's evidence-based and it works. For God's sakes, what is wrong with us? And so it's just unbelievable to me that we wouldn't all just jump at this opportunity to get better for free. Yes. And the other thing, but the reason I bring this up is that people in the program obviously stay sober by being of service to other people every day in the program. And there's so much manpower there to sit on people early in their withdrawal and disease treatment, disease recovery. There's not enough professionals on earth. You couldn't pay enough to get that actually done the way people in the program do it for other people who are suffering. And so it's just, I don't know. And so that program that I was running for all those years was very 12-step based. As that was happening, as I was developing the program, all these alternative, replacement therapies came in and stuff, and they have a role. Listen, I have no problem with anything to help somebody get better. Right. And the real problem is people are so far gone, they're allowed to die in the streets that we have no alternative but giving them replacement therapies of one time or another, because their brains aren't aren't going to be for years able to do the work of recovery.
Yeah.
So we got to save lives. So there's that part. But then I just took the position that, look, I got into this because I was drawn in by the miracle of recovery. I saw what it did for people. It was miraculous. I want to be a part of that. I don't want to be a part of the half measures of giving people meds. And I'll send you somewhere where you can get that if that's what you want, but we're going to be abstinence only, and that's it. And abstinence only, of course, we treated psychiatric illness. Of course, we treated chronic withdrawal. Of course, we treated all these things, but we didn't use replacement therapies. And one of the first things I noticed in things like Suboxone is that as soon as you bring an opioid onto the unit, the whole unit unravels because that guy got that drug and I didn't, and they all want the drugs.
Right.
And so I just said, look, on this unit, the way I'm going to run it, this is not the way every unit has to be run. And there are other areas in the hospital where you can get other kinds of treatment. I make sure of it. But no benzos and no opiates, period. And that's that. So.
And how has your success rate been over the years? So if that was 91.
We were remarkably good. I don't run the program anymore. I stopped doing it like 2011 or something. And but we were doing. We had a reputation for being able to treat the very most ill patients, like the ones that everybody else was done with. We would get, because guess what? People fail replacement therapies all the time. Yeah. And when people were just like, oh, I can't deal with this guy, or they were too psychiatrically ill or too medically ill to go anywhere else, we could handle all of it. And we did it. We had good outcomes. We had a very powerful alumni group. We had supportive services that went on for quite some time afterwards. And so if people stuck around, guess what? They got well.
They got better.
So, but that is you ask a simple question. That's a long answer, long story. All my stuff. There's no blueprint for anything I've ever done, except maybe go to medical school. Even that I was late to. It took me a while to make that decision. But I explore things, and when things interest me, I kind of go down the path. So.
Well, and lucky for all the people that you've been able to treat.
I guess, yeah. Well, and by the way, the great joy, as I was saying. Even when it was, it was not clear they would let us keep going because we were not a good business, was just supporting that, working with that team was such a joy. And then that was the team. Part of that team was what I brought up for Celebrity Rehab. That was same personnel.
I want to get to Celebrity Rehab in a second. But first, look, I'm about to be in my 11th year free from drinking.
Congratulations.
And thank you very much. I have a very hard time calling alcoholism a disease because it was still this hand on my body that was reaching for it that I control with my brain.
Yes.
So that leads to a lot of guilt and shame and terrible things, right? Because I was the one that reached for it, and this is not a personal therapy session, but I need to know, is it a fucking disease?
Okay.
Is it a what?
So can you accept, a lot of Americans have trouble with this, that brains get diseases?
Can I accept that brain? Sure. Yep.
And that when brains get diseases, it affects your thinking and your behavior and your choices and your motivation.
Affirmative.
Alcoholism and addiction, which is really one thing to me, just what your drug of choices is the thing, is a disease of the brain of motivation. It's a motivational disturbance. And once the motivational disturbance kicks in, multiple other injuries come along with that, or phenomena come along with that. So that's one issue. So the question that becomes, if somebody's going to decide, is this a cup or not a cup? Oh boy, don't we first need to define what a cup is? Like, shouldn't we have a definition for it, right? Not just this cup, but all cups, okay? So we have to define what a disease is. Fair enough?
Fair enough.
Okay. How should we do that? What is a disease? What are the components of a thing that will cover all diseases? So then we can say, well, does this thing we call alcoholism fit into this thing this definition we call disease?
I guess it's an imbalance, right?
Sometimes. Of what?
Of the stuff.
Of the stuff. So I'll turn off the card. Don't feel bad because I've asked this question to faculty members in medical schools and things, and they all like, people don't think about these things, and it's important that they do. So the only legitimate, well, let me tell you disease first. Disease is a complex relationship between the genetics of the substrate, the individual, and the environment. So it's a gene-environment interaction that results in an abnormal state of physiology. We call that pathophysiology. The biochemistry is altered in some way that's, you call it out of balance, but I would call it altered in such a way that it creates a natural history, right? And a natural history is a predictable progression of signs and symptoms that end in some way. They either get better, or they become chronic, or they kill the patient, whatever. These signs and symptoms are predictable. And then people like me study those signs and symptoms and try to improve them with something we call treatment. And then we study the treatment so we know which ones are best for the signs and symptoms. So that's disease. Gene environment, abnormal physiology, signs and symptoms that progress in a predictable pattern with a predictable response to treatment. All disease fits into that category. Where people freak out with addiction is the fact that the disease is in the brain. The physiology problem is in the brain. And we want to have free will. We want to be able to trust our thinking. We feel like our motivations are well served. I mean, think about what happens in addiction. Your motivational priorities disintegrate, and one emerges as the only and ultimate priority. And then all the other systems in your brain serve that motivational distortion. Going to work, raising my kids, not endangering other people, my health, all that stuff becomes not important. Using becomes the priority. And I start thinking things to justify that or to make that keep going. That thinking, that stinking thinking, is part of the disease. Then I also lose my impulse control. Like that's part of the progression. You can't control impulses as well.
And but really can't. We can't.
As well.
But there's always a could, right? You always could not reach for that drink.
Yeah. But magically, humans with this condition always do go back. That's part of the signs and symptoms of this condition, that people with this thing can't. If they can stop, they should just stop.
It's so hard.
Right, because they can't. It's just without some kind of something. Yes. Or they go back. The going back is the part that really lets you know that there's been a significant change in the brain. And then denial and all those things. And denial is a very complicated process. It has many different components to it. Some of it's psychological shame and guilt. Some of it is the biology of whatever drug you're using makes you amnestic or forget, or memory isn't working as well. Or you injure your brain, and these drugs and alcohol, they injures your brain, and it's not working as well, so you can't see what's happening. And so there's many, many layers to it. The only legitimate question on addiction is it a disease or is it a syndrome?
Okay.
A syndrome is a constellation of diseases that present with the same signs and symptoms and have varying genetic backgrounds and varying environmental influences. The reality, though, is in addiction, the environmental influence is nearly always trauma, childhood trauma, and the genetics are well worked out. So it's like, it's not a syndrome. You can think of it that way if you want, but it's very predictable, and that predictability is built into the biology.
It's a messy, murky thing to a sufferer, because I hear what you're saying.
And you can think of it any way you want, whatever helps
right.
you.
Either way, it doesn't matter, right? I mean, you can't handle drinking or you can.
I think perhaps you'd find it, because mostly when I would lecture, I lectured every week on this topic for many, many years, and most of the lecture was delivered for the family, because the family they want to blame. Once you start to get better, that's when the family and everybody else unloads. That's when you know somebody's getting better. That's when they unload on the patient. And so the family wants to blame and guilt and, you're so horrible to me, don't you see?
Super helpful.
And right, super helpful when they do that. Not very helpful.
But understandable, by the way.
Completely understandable. Yeah. But where they will really zero in is what you sort of pointed out about picking the drink up. But they'll always say, in the first place. Why did they drink in the first place? If they knew there was any risk here, if grandpa and dad were alcoholics, they must have known there was some risk. They must have felt a little different than everybody else. Why did they drink in the first place, right? And so that begs a good question, right? I mean, if you knew, first of all, you don't really know. I used to, when I first discovered back in the early 90s, we were starting to zero in on some of the genetics of addiction. And I would go, we can take all these kids and we can teach them that they have this risk and they're going to become alcoholics, almost to a child, particularly adolescents. When I would say, we can test you for these genes, or your granddad has it, and you're very high likelihood of getting this thing. And almost to a person, they said, well, if I'm so fucked up, I'm just going to enjoy myself in the meantime anyway. Isn't that alcoholic thinking already, right? And so I thought, oh, this thing is more than just that. So we got to remind ourselves there's a lot going on.
When you say test people for it, do you mean like look at all the factors and add it up?
We have zeroed in on genes that can be tested. It's still not commercially available, but I started seeing that research being done, and I thought, oh, this would be great. Let me start to tell kids they're going to be able to be tested. No, it doesn't matter.
It doesn't matter.
It doesn't matter. But parents want to test. So maybe it would change how people would parent, but it begs the issue why in the first place, and that's the issue of childhood trauma and what's called emotional dysregulation. And the one common trait of trauma is that feelings become too prolonged, too intense, and too negative. And the mechanisms that humans use to develop emotional regulation aren't available to you because the source of your trauma was other people. And it turns out intimacy and closeness with other people is how we develop our capacity for emotional regulation.
Wow. Okay, so all of us sufferers have probably come through some sort of a childhood trauma, and this is how we've learned to handle it. Is that it?
I don't want to be that glib about it because prefer to handle it makes it sort of seem volitional, but it's why you carry around a lot of negative, prolonged, unregulated emotion that get, for the first time, often fixed when you get your hand on that alcohol. And and when you have that, oh my God, I've never felt so good. It's hard to talk a 16-year-old out of that.
Yeah.
Right. And now you're 20 and now it's on. And so, I don't like blaming kids for that or anybody for that. It's how it works. And as I've said, educating everyone about the dynamics of it doesn't change it that much. Maybe it gets you to treatment earlier.
Yeah, right.
Or gets you to do something better earlier. Or, the other thing is there is a piece of addiction where the sort of switch has to get thrown where you lose control. The loss of control is really the point that everyone looks at and goes, now it's a problem. Now it's a disorder, right? When it's affecting functionality and you can't stop it. You can't stop earlier, or you might be able to find ways to drink earlier that you don't lose control. But once you lose control, it's over. There's no going back from that.
Do you feel like there's a genetic predisposition? I know you said there's a test you're working on, but lots of people have trauma and don't become alcoholics,
Correct.
Right?
They don't have the gene. They do other things. They have other problems.
Right.
but they don't become addict alcoholics.
Okay, so alcoholism.
Although let me say that's not, like everything in human beings, you can't say always like that. I mean, there are people that they drink a lot and use a lot of drugs that are not really addicts, but are dealing with trauma. And it's hard to tell them from an addict, except that when they stop, they don't go back.
So interesting.
And then also their family history, you don't see in their family history.
Well, those are the lucky ones, I suppose. Alcoholism, drug addiction, they get a lot of sunshine, right? There's the most celebrated of the addictions. What are some, of the less heroic addictions that we don't hear about?
Well, funny you should ask. I've been thinking a lot about sex and love addiction these days because it is just first of all, I knew Patrick Carnes back in the day, and he got treated extremely unfairly by the medical profession, the mental health profession in general. I really didn't. I was very unhappy about that because he identified a syndrome. He always said, diagnosis or not, DSM-5 or not, doesn't matter. It's a syndrome that I can approach in a certain way that really helps people. And he's helped millions, well, I don't know, millions, certainly tens of thousands of people. And now there are organizations all over the place. And, so many people with addiction have sex and love addiction, with alcoholism have sex. That's a common thing with trauma now. That you say they get other things than alcoholism, this is where a lot of people go with their traumas these days. And now with the phone and the porn, people have a crack pipe in their hand all the time.
All the time.
Yeah.
This phone addiction thing, look, all of us, we all notice it in ourselves of that very first BlackBerry, now with the kids, and it's all off the rails. And where do you stand on there should be warning labels on social media? It's all a terrible addiction. Do you think that it is a DSM level addiction?
I worry about the over deployment of addiction as a model for things. We used to call it process addiction. I think porn addiction definitely exists, whether it meets criteria for DSM-5, whatever. I think it's okay to call something a syndrome. Hypertension is a syndrome, and we treat it all the time. You know what I mean? It's not. It's a syndrome. It's lots of different things. Now, essential hypertension is a diagnosis, but very few people go through the workup to figure out which kind of hypertension you have, and we treat it. I think the same is true with many of these syndromes, like food addiction, like love addiction, like what else out there? Lots of different things people get. Exercise addiction. I think these are real things, but I don't think they're diagnosable conditions. I just think people have to sometimes need help with these things.
Talk to me about love addiction.
Yeah.
What's some of the collateral damage there?
What kind of damage?
The damage that comes from love addiction.
Well, it's a very close relative and maybe even the same as codependency. Okay. And so in love addiction, people over-idealize somebody or other people. They're more quickly drawn into these overly intense, fused relationships, and they actually confuse intensity with love itself. And intensity is what they seek, they think. And oftentimes the kind of people, this is the real problem with it, that they feel that intensity towards, lo and behold, are precisely the same kind of people that were their traumatic perpetrators in childhood, right? So if you have an abandoning alcoholic dad, magically you're incredibly attracted to these guys that are just happen to be alcoholics and don't seem to stay around. It's like, that's the thing. And in treating these conditions, if somebody has these things, you say, look, if you feel lightning bolts and you have this pattern of when you feel lightning bolts, it's a certain kind of person and you're going to have a certain experience, maybe you don't go for it. Maybe you look for butterflies, not lightning bolts.
Can every addiction be treated? This one in particular?
Can every addiction be treated? I think everybody can get better. I mean, I really do. And some seem hopeless. I guess it's that when you say every addiction, I'm thinking about all the different kinds of things that are out there, and some of them don't need addiction treatment. They need other kinds of psychological services and things like that. But in terms of bona fide, hardcore, real life drug addiction, there are cases that seem hopeless. They really do. And yet I've met those people, even when I've kicked them out of treatment and things or declared them hopeless, 3, 7, 10 years later, getting a PhD in psychology and shake my hand and go, I wasn't ready to hear what you said then, but thank you for kicking me out because I remembered that experience and it was part of the building blocks of getting through to me.
Clearly, there are many, many different ways of getting somebody sober, whatever their addiction may be. Is there a through line in terms of this is the formula? There's this much talk therapy, drug therapy, 12 steps, God. I mean, is there a formula?
You're making me think because...
I'm sorry.
No, I'm sorry too. But because the answer is there are people that use formulaic approaches and they're extremely good and extremely helpful. But the answer is no to your question. That everybody needs a little bit of this, a little bit of that. That's why there are treatment plans. That's why people try to put together things that they think are the right combination of interventions for a given individual. And ultimately, look, the individual's in charge of their care. They can choose not to do certain things and choose to do others. It's just that in particularly early in addiction treatment, it's almost impossible to differentiate resistance or actually just simply choosing you don't want to do something with the disease having its way with you and just finding its way back into a relapse. It's very hard to tell. And I would always take the position that, look, if you're really not listening, we're telling you this is an important thing to do and you're not doing it, that's probably your disease.
Yeah. And it's really murky. I keep going back to that, but it is murky whether people that you love, respect, trust are telling you it's a bad idea to do what you're doing, you still don't do it. I guess that is the disease.
Well, I don't know. You have to get a little philosophical about it, right? And this goes, interestingly, dovetails into what you were asking about the disease model itself. Like, well, where is my free will and where am I in all this? Where does me figure into this? And it's really a hard, particularly in that first year, it's a hard thing to figure out. Afterwards, it's much easier because you can trust your thinking a little more and your motivations have settled down. And
the first year's the worst.
Yeah, the first year's rough.
Yeah, I hate it. So speaking of people getting sober, I think so much of America came to know your work through Celebrity Rehab.
Yeah.
What I have to wonder is, how does it change things when you have cameras rolling on your process to get sober versus not, especially if you're a person who might even be addicted to that type of attention?
Yeah. So very challenging, very concerning. I was mortified. Like I was so worried about that the first season particularly. And there is a comical story attached to this. Every day at group, I'd go, "Are you okay? Do you need me to send you to a hospital? Are you gonna? Is this going well for you?" I mean, none of them. This was. I'll tell you that story in a second. But they were all surprised how seriously we were taking the treatment. But when you take something seriously, that the patients participate with you. So every day I was like, "Are you sure you're gonna be able to do what you need to do?" And one of the hard things for me was when somebody was telling me when I was interacting with somebody on an intensive level, and I didn't feel like I was getting an honest answer from them, which is 90% of what I had to do in early treatment is what's real and what's not.
What do you mean? Alcoholics don't lie. We
just
don't do that.
Constantly. And so I have to my job is to figure out what's true and not to expect them not to lie. I mean, the funniest thing in the world to me is my peers get upset if their patients lie. I mean, my patients didn't lie, their diagnosis would be wrong.
Right.
So, so when they would start doing that, I would think, is that withdrawal? Is that bullshitting? Is that them just not wanting to say something on camera, which I should protect? So I'd push the way I normally do, but I wouldn't push as hard because I'd go look, if they don't want to say it, no problem. And so there was that dance for me. The going in every day and saying, "Are you okay? Are you okay? Are you okay?" Because I was so anxious. About 2 weeks in, Mary Carey, who was a porn star, she leans in and goes, they were all very nice. We're like, no, we're fine. And finally she leans in and she goes, "Drew, I have done just about everything in front of a camera. I understand what this is to do something like this in front of a camera." And I thought, oh yeah, they do understand what this is to be vulnerable in front of a camera. And they all agreed with her, by the way. And this extraordinary thing happened in every season, which I did not expect. They went from the entire group would go from coming in resistant, not really wanting to be there, / wanting to screw us up, like really wanting to sabotage everything and get paid and be on TV and all those things. They would all go from that to, "Oh my God, this is serious. Oh my God, I'm getting something out of this. I want to be a role model for other people." That was mind-blowing to me. I was so grateful for that. But every group went through that same sort of process. And so who knew that was going to happen? So, and the other thing was, because they wanted to be on TV and wanted to get paid, I could really push on them in ways that I do not do in normal treatment because people will leave. They leave all the time. But I could really push. And that was amazing. And so we could make a lot of progress rather quickly.
That's wild. So it sounds like in this case, having the cameras there actually really hastened recovery.
Maybe it seemed to. I mean,
Did
it
people
wasn't
stick with
formally
it?
studied, but it certainly didn't seem to hurt anything. And a lot of people stayed. A lot of people did amazing. People that didn't do so well were either opiate addicts. The things that people do, I hope they understand now that, like somebody like Mike Starr, we got him. He was a legendary drug addict, and we got him sober. He was sober a year. We couldn't believe it. And all of a sudden, he says to me and Bob, hat and glasses, Bob Forrest, he says, "I'm moving to Utah." We're like, Mike, you're doing so well. Don't do this. "Oh no, I'm going to live at Cirque Lodge. I'm going to be in a sober living. I just have to get my band going again. And all the band guys are sober, and we're all going to live in the same sober living setting." And we were like, something doesn't feel right. Something's not right. Fast forward about a month, he calls me, or maybe a couple of weeks, and he goes, "I'm having back pain." And I go, "Mike, whatever you do not tell a doctor. Where's the camera? Do you understand what happened during the opioid crisis? If anybody came in, even a heroin addict comes in and says, 'I have back pain,' he would walk out with 60 Vicodin and 60 Soma." Exactly what happened, dead a week later. And that's what was killing all of my patients. It's one of the reasons I got out of the treatment field. I couldn't stand that anymore. It would just, I would get people, we had really sick people. We'd get them well, we'd get them going, and my peers would kill them.
Oh God.
Yeah. And the folklore on that is, oh, you shouldn't have had them abstinent. They should have been on some replacement therapy because they're just taking their usual dose. No, they weren't taking their usual dose. Their usual dose was a whole bunch of heroin.
Yeah.
You gave them a bunch of Vicodin, and you gave them a benzodiazepine or a Soma with it, and that's a lethal combination. And my patients will die of that when you give that to them. So it's crazy. So anyway, there were, as always in every group, there was some. It's a deadly, deadly, deadly disease. It's terrible.
I didn't realize you weren't in the treatment field anymore.
No, I'm not doing it. A day doesn't go by that I'm not asked to do something, but I don't run a program anymore.
Because it was hard on your heart?
It was, the writing was on the wall because we're not making money for the hospital. I got really tired of having patients die. The opiate thing was just so out of hand. It was killing me. And I just thought it was time. I'm not sure that I was as into it as I had been in the past. And it's an interesting question. I didn't really, it just sort of naturally happened. It was, sort of time to go.
I understand that.
Yeah.
There's nothing more hopeless than thinking you can't get sober. And so I'd really love to leave our listeners, our viewers with, you're a man with a lot of experience. You've seen a lot of people come and go through treatment rooms. What's the most hopeful thing we can let people know?
Where my head goes immediately with that is that the most hopeful thing is that anybody can get better, no matter how hopeless they seem. I've seen it. It's what gives me hope for the next one. The situations that I thought were completely hopeless, people just surprise me. I've also had people that I thought were going to do great that didn't do so great. So you can't predict what's going on, but anybody can get, miracles happen all the time. I'm going to say three things. Miracles happen all the time. If you just do what they tell you to do, you'll get better. It's pretty simple. Just follow direction, surrender. Surrender is the goal. Surrender, follow direction. And that what I have seen and the thing that kept me in the field for so long, for 25 years I was doing it, was what we call the miracle of recovery. The people become, it's almost uncanny what people are able to do once they recover. And the addicts are rich, wonderful, smart. It's one of the reasons I like working in the field. That's part of the.
Thanks, Drew. I do feel.
No, they are. They are. And by the way, back when I have a whole story around this too. But when they started talking about isolating the gene for addiction and then maybe aborting babies that have the gene, I was like, oh my God, we are going to lose something profound from the population. This gene isn't here just because it caused disease. It's got a lot of other good stuff that came with it. And addicts they make great fighter pilots and they're brilliant, and a lot of poets, all kinds of things. Anyway, when they're in recovery, all that blossoms and comes forth. And it's just, the miracle of recovery is a miracle. And you'll see people do things, people you might have stepped over at one time, doing extraordinary things. And that's what everyone should feel good about.
All right. Well, I'm certainly going to take that with me. Listen, there's not a day that goes by, even with 11 years off the sauce, that I'm not, I don't know, maybe just one glass. Like, I'm still not even sure I've made it to the surrender part. Like, I'm pretty confident that I'm not really an alcoholic, even though I've blown up my life several times over.
Not being fully surrendered is common. And, but you will still get a lot out of it, I promise.
All right. Thank you, my friend.
Good to see you.
Good to see you.